Hello everyone, and welcome to today's presentation. I'm excited to have you here as we explore biases in clinical trials and their elimination. This is the title of our session, and it highlights a crucial aspect of medical research. During our time together, we'll look at common biases that can affect clinical trials and discuss strategies to eliminate them. So, let's get started and dive into this important topic. Bias is defined as any process at any stage of inference that tends to produce results or conclusions that differ systematically from the truth. It's important to understand that biases can sometimes be confused with random error, and in many cases, they cannot be easily identified. Random error, on the other hand, is related to sampling variability, which is an unavoidable aspect when we study a sample of patients instead of the entire population. Now, while random error can often be reduced by increasing the sample size, biases are different. Some types of bias are systematic and do not depend on the size of the sample. These biases can occur at three key points in a study: during the initial enrollment of participants, during the implementation of the study, and during the analysis of the findings. This is where the concept of levels of evidence becomes important. These levels reflect the relative risks of bias associated with different types of studies. So, understanding and controlling bias is crucial because it directly impacts the validity of our conclusions, and it ties into the overall goal of ensuring that our research findings are as accurate and reliable as possible. The first source of bias we need to consider comes from the lack of a control group in descriptive studies. Now, descriptive studies, like cross-sectional studies and case series, focus on a specific group of patients chosen based on a particular characteristic, such as a certain disease or treatment. They describe how these patients evolve over time, for example, how their disease progresses with a new treatment. Unlike analytic studies, such as case control studies, cohorts, or randomized controlled trials, these descriptive studies don't include a control group for comparison. And this is a key point because, without a control group, it becomes much harder to determine whether the observed outcomes are truly due to the treatment or other factors. So, if we observe a certain recovery rate in these patients, that rate could be influenced by multiple factors. It might be related to the treatment itself, but it could also be affected by the patient's initial characteristics, the natural course of the disease, the placebo effect, or even phenomena like regression toward the mean when comparing pre- and post-treatment values. In essence, without a control group, it's challenging to distinguish the actual effect of the treatment from these other parameters, which is why understanding this bias is so important in the design and interpretation of studies. Let's talk about types of bias, starting with selection bias. This occurs when there are systematic differences between the baseline characteristics of the groups we're comparing. In other words, the groups might not be truly comparable at the start, which can skew our results. Now, a key strength of randomization is that, if done correctly, it helps prevent this type of bias. When randomization is successful, it ensures that participants are allocated to different interventions in a way that's free from subjective influence. But achieving this success depends on several important steps. First, we need a clear rule for how interventions are assigned, and this rule must be based on some chance process, what we call sequence generation. This means using a genuinely random method to decide who gets what. Second, it's crucial to prevent anyone from knowing upcoming assignments. This helps secure strict adherence to the randomization schedule and prevents foreknowledge, which could introduce bias. By carefully implementing these processes, we strengthen the internal validity of our study and make sure that differences we observe are truly due to the interventions themselves, not some pre-existing differences. This ties back to our overall goal of conducting rigorous, unbiased research. Now, moving on, it's crucial to take steps to ensure the strict implementation of the random assignment schedule. This means preventing anyone involved in the trial from knowing what the upcoming allocations will be. We often refer to this as allocation concealment, but a more precise term would be allocation sequence concealment. One effective method is to use a simple random sequence that's unpredictable, so no one can foresee what the next assignment will be. Along with that, it's important to hide these upcoming allocations from the people enrolling participants. This helps prevent any bias that could influence who is assigned to which group. Speaking of bias, it's essential to consider both how large the bias might be and in which direction it could push the results. For example, if we know that certain methodological limitations tend to underestimate the effect, biasing results towards no effect, and we see evidence that the intervention actually works, then we can be more confident that the intervention truly is effective. This approach helps us interpret the evidence more accurately and ensures that potential biases don't lead us to underestimate the real benefits of the intervention. It's all about maintaining the integrity of the study and making sure our conclusions are as reliable as possible. Let's talk about some effective ways to address selection bias in studies. First, proper randomization is crucial. By using a strong randomization process, we can ensure that patients are equally distributed across different treatment groups, which helps prevent any systematic differences. Next, blinding is key. When both researchers and patients are unaware of who is receiving which treatment, it reduces the chance of conscious or subconscious biases influencing who gets included or how outcomes are interpreted. Lastly, having clear inclusion and exclusion criteria is essential. When we define these criteria precisely, it minimizes subjective judgment and ensures that participant selection is consistent and objective. All of these measures are vital to maintaining the integrity of our study and making sure our results are valid and reliable. Let's talk about performance bias. This refers to systematic differences between groups in the care they receive or in their exposure to other factors beyond the actual interventions we're studying. Essentially, even if the intervention is the same, variations in how participants are treated can influence the outcomes. After participants are enrolled in the study, blinding or masking can play a crucial role. Blinding helps reduce the risk that what participants or staff know about the intervention influences the results. When people don't know which treatment they or others are receiving, it minimizes bias caused by expectations or behavior changes. Effective blinding also ensures that both groups get similar attention, ancillary treatments, and diagnostic tests. This way, differences in outcomes are more likely due to the intervention itself rather than other factors. However, it's important to recognize that blinding isn't always feasible. For example, with major surgery, it's usually impossible to blind either the patient or the surgeon to whether the procedure was performed. So, understanding and addressing performance bias is key to maintaining the integrity of our study results and ensuring that the differences we observe are truly due to the interventions we're testing. Let's look at some examples to understand how bias can creep into studies. For instance, if a weight loss study is testing whether a high-protein diet helps people lose weight, participants might start eating more protein simply because they believe it will work. This change isn't necessarily due to the diet itself, but their expectations can influence the results. Another example is when a new pain medication is being compared to a standard one. If the clinicians who are giving out the new medication are more enthusiastic or optimistic about it, they might unconsciously give more supportive care to those patients. This extra attention can make the new medication seem more effective than it really is, leading to biased outcomes. So, to address these kinds of biases, we use blinding or masking techniques. In a single blind study, the patients don't know which treatment they're receiving, so their expectations don't influence the results. In a double-blind study, both the patients and the healthcare providers are unaware of who's getting which treatment. This helps prevent bias from either side clouding the results. And in a triple-blind setup, even the data analysts are blinded, further reducing any potential for bias during data interpretation. These blinding methods are essential tools to ensure our study findings are as objective and reliable as possible. Now, let's talk about some key strategies to ensure our intervention is delivered consistently and effectively across all participants. First, developing standardized treatment delivery protocols is essential. These are clear guidelines that specify exactly how the intervention should be administered, so no matter who is delivering it, the process remains uniform. This helps us minimize variability and maintain the integrity of our study. Next, centralized monitoring plays a crucial role. By having a dedicated team oversee data collection and treatment delivery, we can ensure everything stays on track. This team acts as a quality control checkpoint, catching any deviations early and making sure that the treatment is being delivered as intended across all groups. Finally, training healthcare providers is fundamental. We need to educate clinicians involved in the study about the importance of strict adherence to the protocol. This training also emphasizes avoiding any unintentional bias during interactions with patients, which is vital for maintaining the validity of our results. When we combine standardized protocols, centralized oversight, and thorough training, we create a robust framework that supports consistent, unbiased, and high-quality intervention delivery, aligning perfectly with our overall goal of conducting a reliable and valid study. Detection bias occurs when there are systematic differences between groups in how outcomes are determined. It's important because such biases can skew the results of a study. One way to minimize this is through blinding or masking of outcome assessors. When assessors do know which intervention a patient received, it reduces the chance that their knowledge influences how they measure outcomes. This is especially crucial for subjective outcomes, like pain levels after surgery, where personal judgments can easily be affected. For example, if a doctor knows that a patient received an experimental drug, they might unconsciously interpret the results more favorably for that treatment. This can lead to an overestimation of the treatment's effect, simply because of preconceived notions. To prevent this, we use remedies like blinding and concealment, making sure the assessment process is as objective as possible. Ultimately, minimizing detection bias helps us obtain more accurate, reliable results, which ties directly into our overall goal of improving study quality and validity. Let's talk about attrition bias. This type of bias happens when there are systematic differences between groups in terms of participants withdrawing from a study. When people drop out, we end up with incomplete outcome data, which can affect the validity of our results. There are two main reasons why withdrawals or incomplete data happen in clinical trials. One is exclusions, where some participants are left out of the analysis report, even though their outcome data are available. The other is attrition, which refers to situations where the outcome data are simply not available because participants have dropped out or are lost to follow up. For example, imagine a study testing a new pain medication. If more participants experiencing mild pain drop out from the treatment group, and only those with severe pain remain, the results could be misleading. It might look like the medication is more effective than it actually is because the analysis is skewed towards more severe cases. This highlights how important it is to carefully consider attrition bias when interpreting trial results. It can significantly impact the perceived effectiveness of an intervention, so understanding and addressing it is key to ensuring reliable findings. Let's talk about some effective remedies to improve participant retention in our studies. First, clear communication is essential. We need to ensure that participants fully understand the study protocol, including any potential side effects, so they feel informed and confident about their involvement. Emphasizing how important it is for them to complete the trial can really motivate continued participation. Next, offering incentives can make a big difference. Small rewards or tokens of appreciation for attending follow-up appointments can encourage participants to stay engaged throughout the study. Finally, flexible scheduling is key. Making it convenient for participants to attend study visits, whether by offering appointments at different times or locations, helps reduce barriers and shows respect for their busy lives. All these strategies connect to the broader goal of maintaining trust and engagement, which ultimately leads to more reliable and meaningful research outcomes. Let's talk about reporting bias. This occurs when there are systematic differences between findings that are reported and those that are not. In other words, some results are more likely to be published than others. Within a published study, analyses showing statistically significant differences, so clear and positive effects, are more often reported than those with non-significant or inconclusive results. This phenomenon is known as outcome reporting bias or selective reporting bias, and it can be one of the most substantial biases influencing the validity of individual study results. For example, imagine a researcher or a company that only chooses to publish the positive outcomes of a trial, while ignoring or hiding the negative or inconclusive findings. This can create an inflated perception of a treatment's effectiveness. A common real-world example is when a drug company publishes only the trials that show a new medication works well, but doesn't report the trials where the drug showed no benefit or even caused harmful side effects. This kind of selective reporting skews the overall understanding of the treatment's true efficacy and safety. So, understanding reporting bias helps us critically evaluate research findings and recognize that what's published may not always tell the full story. Let's talk about some key remedies to improve trial transparency and integrity. First, pre-registering the trial protocol is crucial. By doing this, the company commits to reporting all planned analyses up front, including the primary outcome, even if the results aren't statistically significant. This helps reduce the risk of selectively reporting only positive findings, which can skew the overall understanding of the trial's results. Next, following the Consolidated Standards of Reporting Trials, or consort guidelines, ensures that all relevant details are clearly reported in publications. This includes methodology, inclusion and exclusion criteria, and all outcomes analyzed. It's about making sure the information is comprehensive and transparent for everyone reviewing the research. Another important point is the role of independent data monitoring committees. These committees can review data as it's collected and raise concerns if they notice any signs of selective reporting or biases. Their independence adds a layer of objectivity and oversight. Open access data sharing is also vital. When trial data is made publicly available, it allows other researchers to verify results independently and spot any potential biases or inconsistencies. Finally, funding transparency plays a key role. Disclosing who funded the study helps identify potential conflicts of interest. Knowing the funding source allows us to assess whether there might be bias or undue influence affecting the reporting. All these remedies work together to promote honesty, accountability, and trust in clinical research, aligning with the overall goal of improving transparency in the field. Now, let's look at some other biases that can come into play, but typically only in specific situations. These biases are often linked to particular trial designs. For example, in crossover trials, carryover effects can occur, where the effect of one treatment might influence the next, potentially skewing results. Similarly, in cluster randomized trials, recruitment bias can be an issue if the way participants are selected differs between clusters. Some biases are more widespread, but only become relevant under certain conditions. Take contamination, for instance, where the experimental and control groups might inadvertently exchange interventions, for example, participants sharing or pooling their medications, leading to mixed effects that can muddy the trial outcomes. And finally, there are biases that might only appear in specific clinical settings. These are less universal, but just as important to recognize, because they can significantly impact the validity of the findings in those particular contexts. Overall, understanding these nuanced biases helps us better interpret trial results and ensures we're considering all potential sources of error that might influence the evidence we rely on. This slide doesn't contain enough information. That's why we're moving to the next slide.